Good morning. It's my honor and pleasure to present our lectureship, Dr. Katherine Deans, who's here with her also excellent and accomplished husband, Dr. Pete Manecci. They're a duo, although Dr. Deans is going to give our talk today. Dr. Deans grew up on the East Coast in Philadelphia and spent besides 1 year that she spent in Long Beach in California. And from there, she went to Wellesley as undergrad, medical school at Dartmouth. She did her residency training at Mass General Hospital in Boston. From there, she spent 4 years at the NIH doing a variety of work there, including a critical care fellowship, as well as getting a master's in clinical research. From there, she went to Children's Hospital of Philadelphia, CHOP, for her pediatric surgery fellowship, which is well known to our division as well as one of our partners, recently trained at CHOP as well. From CHOP, she went to Ohio State University, Nationwide Children's Hospital, which is where I had the pleasure of learning and training with both her and Dr. Manecci. They've been there for about 9 years now, which is a very long time, and too long, I say. They have two wonderful teenage children, and they are the directors of the Surgical Outcomes Research Group at Nationwide Children's Hospital, which is one of the premier outcomes research groups in pediatric surgery, and really leading the field in outcomes research within not just pediatric surgery, but also, I think, all of medicine. So with that, it's my pleasure to introduce Dr. Katherine Deans.
Good morning. So unlike when you guys travel east, the time change is to my benefit. This is probably the most awake I've ever been at an M&M in my entire life. So I was very tuned in and focused in. So I have a lot of energy today, so I probably will end up talking a bit fast. Let me just make sure I clear this here. Get this up here. Hold on one sec. So I do this right. And I'm going to test this mouse function out because I've never used this before. So do I point? Oh, perfect. Okay, great. So today I'm going to talk to you about the value of listening. The photo that you see on the left, that's my husband Pete and our daughter Sarah. It was about 12, 13 years ago now, something like that. We were on vacation, and she was 4, and she was telling a very convoluted and likely fictitious story that only a 4-year-old can do. For those of you who have children, they go on and on and on. And at the time, we had Blackberries. And did anybody have a Blackberry? You guys all look too young to ever have had a Blackberry. So we had Blackberries, and Pete pulled his Blackberry out and was doing something on an email or something like that. And Sarah reached over and grabbed his hand, pulled it down, pointed at him, we got this picture, and said, "Daddy, you need to do better listening." So I thought this was pretty apropos for the talk today, because really what we did at Nationwide, I'm sorry about that. It's not what I'm used to seeing. Really what we did at Nationwide is we developed a clinical outcomes research center that was based on the needs and desires and challenges that we heard about from our patients. The mission of our research center was to improve the care of children through rigorous patient-centered outcomes research. And this patient-centeredness has now become kind of jargon-like. You know, initially people 20 years ago talked about outcomes research, and then it became then it became quality, then it became comparative effectiveness, and now it's patient-centered. It all kind of means the same thing, except there's a little bit of a nuance with this. And the nuance is that in patient-centered outcomes research, you're really supposed to incorporate the patient in all aspects of the research process. And so that was a core value for us in developing this center. So we have patients involved in picking what we study, designing the study, implementing the study, not so much in the analysis, but certainly in how we report the results and then how we disseminate the findings. So for the next 40 minutes-ish, I think that's about what I have, I'd like to share with you 4 patient stories and how each one of these shaped this mission. I chose them very intentionally because each one received extramural funding, and I think the reason why they received funding is because that patient voice kind of resonated outward. And so a little sidebar here for the residents. How many are residents or trainees? So lots. Okay. When you start deciding what you want to do with your career, it's really important that you do what you want to do, okay? What you're passionate about. I've always been passionate about patient experience, and patients as research subjects and making sure they're protected as research subjects. So that's kind of like my background. So when it came to building a clinical research center, studying like wound infections, kind of NISQIT metrics, that didn't really resonate with me as much as trying to improve the patient experience by leveraging and harnessing and echoing the patient voice and what they wanted in clinical care. So that's my story, but you guys each have your own story and what you need to study, and it's really important you stay true to that when you move on outside of training. So this was our first patient. His name is Jared. He's 11 years old. He came to the hospital with acute early appendicitis, and this was probably 12 years ago or so. Like all kids with early appendicitis, we give them make the diagnosis, give them antibiotics, make them NPO, and book them for the OR the next day. Better not to operate in the middle of the night if you don't have to. We know that in appendicitis care. So the next morning on rounds, he was better. He felt fine. He had a lot of energy. He was hungry. He didn't have any pain anymore. And his family had been planning this scuba vacation to the Caribbean. And so his dad asked the question, does he really need an operation? We're going to miss our vacation, lose all our money, etc. And that was over 10 years ago. And so in the United States, there was no data to suggest that non-operative management of appendicitis was safe and feasible outside of the military practice. But there was some data in Europe at that time. But that wasn't our practice, and the surgical dogma said, no, you need to operate. And I was a brand new junior faculty member, so I was not going to deviate from surgical dogma. And so I said, I'm sorry, we need to do this appendectomy. And they missed their vacation, right? And he did fine after surgery, no complications. But it was this patient and others like him who came in with this early appendicitis that got better overnight that prompted both Pete and I to say, is there another way, not necessarily a better way, but is there another way that we can do this? So if you think about the last 20 years of surgical care, okay, for those of you who trained prior to 1995, if you came in with early diverticulitis, you were admitted to the hospital to a surgical service, you had a sigmoid colectomy with a Hartmann's, a stoma, and then you came back sometime later and you had your stoma taken down. Now you don't even see diverticulitis, right? Coming into the hospital admitted for simple diverticulitis. And it's really for two reasons. Number one is the availability and bioavailability of good antibiotics to treat polymicrobial infections in the belly have come about. So in the last 20 years, our antibiotics have gotten a lot better. And we can take them orally now too, so they don't have to be IV in the hospital. The second is imaging. So what happened when I trained between fourth year medical school and internship was this thing called the CT scan. And we used to have them on the wall in the radiology department, and we'd have these little magnifying glasses. You had to look at all the little squares to see what was going on. Well, CT scans came about. And so our diagnosis was better. And so we could, with greater sensitivity and specificity, diagnose not just the problem, but the severity of the problem in the belly. And in pediatric healthcare, the ultrasound, which was used very commonly, much more than we do in adults, became much more accurate. So here we are with something simple, like uncomplicated early appendicitis. We can now diagnose it more specifically and its severity, and we've got great antibiotics to take care of it. So just like diverticulitis that evolved to primary medical management when it was early, so did tubo-ovarian abscesses, small intra-abdominal abscesses for Crohn's disease. Perforated appendicitis went the way of non-operative management for many cases. So we thought, let's give it a shot. So we set out with our first pilot study asking if antibiotics alone for appendicitis was a safe and feasible thing to do in kids. Now the general surgeons in the room, you did not like this idea, okay? We presented this idea at multiple meetings, American College and other adult surgical forums, and there was actually a time Pete almost got booed off the stage. You and Dave Flum, I remember that. So whenever you have an idea, if it's resonating with people and they're fighting you on it, it's typically a good idea, so stick with it. Another little pearl to the residents. So we did a small, safe patient choice study. We enrolled kids ages 7 to 17 years of age who had abdominal pain for less than 2 days, a white count less than 18, no peritonitis, and they had ultrasound or CT confirmed early appendicitis. Okay, so that meant the appendix was less than 1.2 centimeters in maximum diameter, there was no free fluid, and there was no fecalith. We chose these inclusion criteria to be very, very safe. So we looked at the 7-8 trials that had been done across Europe and drew from them the population that we thought that we could extrapolate to children, which would make this a successful intervention. So we took 100 kids and we said, what do you want? Do you want antibiotics? Do you want to give it a try? Or do you want surgery? And a third chose antibiotics and 2/3 chose surgery. And this is pretty consistent across the subsequent, like almost 3,000 now kids we've done this on. But the point is that about a third of families want to try antibiotics because it's more aligned with their preferences and their values and how they view surgical interventions. And I'm going to talk about that in a minute. And so we found that with antibiotics alone, 94% of kids made it to discharge with their appendix. 90% made it to 30 days, 76 made it to a year, and roughly 70% made it to 2 years and 3-year follow-up, still having their appendix in place. They also reported, both the families and the children, better quality of life at 30 days, fewer disability days at 1 year. And when we looked at healthcare costs, we found that there was about a 20% reduction in healthcare costs, and we at Nationwide Children's have a big, it's like the largest pediatric accountable care organization, which means, we're in charge of all the finances around pediatric health for these patients. So we were able to use some of that data to look at this. And about a 20% reduction overall in healthcare costs, which is important for our healthcare system. And that even includes those kids who failed, who came back, got readmitted, and had an operation. So even including the failures, it's reduced. But I'm not here to talk to you about the data from all this research, and you're going to see that this is actually a very, very data-poor presentation. For all the scientists in the room, you're probably cringing. But the reason why it's data poor is because that's not my point today, is to talk to you about the data. My point is to talk to you about why it's important to listen to families and kids. And for most of you, you're adult patients. And so our next step in this process was to convene what we call a stakeholder team. It's something we do across most of our research programs. That stakeholder team consists of anybody who's an end user for either the intervention or the population or whatever you're studying. So for appendicitis care, intuitively, that's patients and families, primary care docs, ED docs, surgeons, nurses that go across the entire arc of care, health educators, and for us, payers were important. And we asked this group through structured interviewing, group interviewing, surveys, et cetera, what do you think we should do with this data? What would you think is the next step for this data? And they gave us really two things, because we thought they were going to say, do a large RCT. No, that was actually not it at all. The first was they thought we should take our pilot model, our choice study, and we should throw it across a bunch of other institutions. And so we did that across 10 other children's institutions in the Midwest. And then the second was to do a trial, so a randomized controlled trial, but not of operative versus non-operative care. They wanted us to study if an iPad app that could improve shared decision making would actually help families with the stress of going through emergency services and having your kid have surgery, et cetera, et cetera. That's actually what they cared about, was more the shared decision model than anything else. They felt the European data and our data and the small amount of other US studies was compelling enough to offer this in clinical practice. So I'm going to talk to you more about that second study, because that second study is the one that highlights the role of the stakeholder team. Both these studies are done, they're completed. The multi-institutional trial is coming out this spring in a surgical journal near you, and we are very happy about the results, so I will say no more. The second one has also been studied already and basically showed that using the iPad app maybe didn't help improve decision making, so all that technology maybe wasn't the best thing to do. A good surgical consultation with a paper decision aid tool and an informed surgeon who's willing to partner with families on making decisions was adequate. So in this PAT study, that was the objective, to see if we could use this iPad app. And there were really three things we wanted to accomplish, and this was all based on what the families said they needed. We needed to activate families. So you guys just heard about that complication today with the kid who had the redo anoplasty. And you heard the subtle comments around, well, the family might not be so engaged or so activated in the kid's care. Patient activation has been shown to improve all metrics of patient care in both adult and pediatric populations. There's a lot of data out there on that. And so we used different kinds of tools to activate families to get them involved in their kids' care. So we wanted to do that. The second was we want to talk about risks and benefits and do it in a very dynamic way on this iPad app. And then the third was to make sure if they had any decisional uncertainty that we could mitigate some of that through the application. So it was a single center RCT with 1-year follow-up. The patients were the same that we had put in through all of our other appendicitis studies. And the control group got standard surgical scripted consultation, and the treatment group got an iPad app plus the standard surgical consultation. And these were the outcomes that we cared about. So I want to just click into this app real quick. This was designed by the Stakeholder team. So we had the kids and the families meet with a company that helped us develop the app, and they really did it from start to finish. We had 2 fictitious doctors. No one looks that good in scrubs. 2 fictitious doctors come on, introduce the app, say, hey, we want you to be part of decision making. Your voice is important. They're kind of like cheerleaders for shared decision making. And then we allowed the families, kids got an iPad app and adults did, to choose their avatar to guide them through the process. We showed them videos and pictures and all these kinds of things about surgery and also antibiotic management. And then it built a 2x2 table that showed them the risks and benefits of each. Then it takes them through little vignettes from parents and children who had both of the treatments and kind of what their concerns were in a very qualitative way. And then it allows them to pick out a feature that was most important to them in this decision-making process and put it on a Likert scale as most important and least important, such that they could print out a summary of their preferences so they had that to talk to the surgeon with. And this is all happening in the emergency room. And then they can go back and look at all the different modules if they need it. So again, what I really want to focus on here is not so much the results of the study, but how we did it and the stakeholders' role. So number 1, they chose what we studied. Number 2, they pretty much developed the app. The third thing that we like to get them involved with is like operationalizing the research. And this is the part where, I get a little cocky. So we had to have, we were funded by PCORI on both these trials, and PCORI, if you have these stakeholder teams, you have to have a certain number of in-person meetings with these stakeholder teams. So we were scheduled to have our first annual in-person meeting with this large team. And what we really wanted to talk about, like in all trials, is recruitment and retention, because those are like the Achilles heels of clinical trials, right? And so we went into this meeting thinking, all right, we'll talk to these guys about these things, but they don't do clinical research, right? Like they don't really know how I'm going to improve recruitment or how I'm going to improve retention. So by way of reference, in a pediatric clinical trial, a recruitment rate of about 30% is considered good, right? Surprising. It's hard to think about how that data is even generalizable at all, but in clinical trials, 30% is good in kids. We were at 65%, so we thought we were doing pretty good. But here's the thing, Pete and I, when we talk about this trial and the intervention we had, we weren't doing anything to patients, right? There's no risk. We're giving them an iPad app. So why did 35% of families not want to have an iPad with them while they're in the ED, right? It didn't make a ton of sense to us. So we thought we would bring it up to the stakeholders. And they had a bunch of feedback. They made us act out how we do the recruitment process and approach families. And then they had us make changes on how we, physically how we approach them, who should be doing it. They altered our script and how we described the study, the language we used in several ways. And by the way, we had a communication expert from the College of Medicine at Ohio State who was part of this. So we thought our communication was pretty good. So we put these things in play, and we didn't think it was going to do much. And lo and behold, our recruitment jumped to 95%, and we retained that for the remainder of the study. So we did the same thing around retention. So retention 50% is not so great, but that's kind of what's reported in pediatric trials. We were at roughly 58%. We asked the stakeholders what to do, and they gave us a bunch of things. Now this is all going to seem simple and intuitive to all the millennials in the room, but it was not to me. They said, have your follow-up be done through social media platforms, have texting options, don't do everything by email and phone calls. Ask the families, what day are you available for me to call you before they even start the study, because then you know when they're home. All these different kinds of little itty-bitty operational things. And what happened is it took our retention up to 85%. And if we didn't listen to these families, we would have had persistent recruitment at 65%, retention at 58%, and that would have prolonged our trial for 40 months and cost an additional $1.5 million. So I'm really glad we listened, right? And we listened to people who we didn't think were going to be able to contribute in this process because they're not clinical researchers, but they know who they are, and they are the end user and our target for the study. So here's a second vignette. So this kind of patient is not one you frequently see in adult healthcare, but it's very frequent in pediatric healthcare. This is Tommy. Tommy is a developmentally delayed, non-communicative teenager. And he has a VP shunt, and he's G-tube dependent, and he's a very complex, fragile medical patient. And so he came into our hospital with abdominal pain. And in many children's hospitals, if you get a non-communicative kid come in and they come in with some kind of abdominal complaint, they go immediately to CT scan. Maybe not surprising in adult health care, but we try not to do that in pediatric health care. And so he was doing that. And his mom actually turned to me and said, "Do you think he's received too much radiation from CT scans?" And I thought, I have no idea, right? So I don't know how you guys are on Epic, I heard today. So we're on Epic too, the world of Epic. Our radiation reporting system is separate from Epic. So yes, we can get one image or we can get a report of results, but we can't archive all the imaging a child has. So there's no access to that. We'd have to go into PACS, pull the archives from PACS, sit there, look through them all. And even if we were medical physicists and knew how to calculate radiation dose and its importance in malignant degeneration, we wouldn't even have the time to do it, right? So it's kind of impossible to answer this question. But this is not uncommon in kids who get lots of CT scans. Their parents really want to know what their risk is of having so much medical imaging. So we decided we were going to come up with a research program to address this. By way of background, medical imaging is the largest source of ionizing radiation to the U.S. population. There's over 7 million CT scans performed in pediatric patients annually, much more in adults. And because children are growing organisms, and I hate to tell you this, but you're all dying, because I imagine you're all above 30, okay? The children are growing and developing, and so they are more susceptible to the effects of radiation because of their tissues. And they have a long life expectancy, right? So if I image a kid 100 times before they turn 17 and then throw them to you, they're going to get imaged another 300 times potentially as an adult. So that's a lot of CT scans over the course of your life. So we decided we wanted to see if we could develop an automated software tool that would calculate radiation exposure from CT scans, but also then merge it with the data elements from the EHR so that we could do a couple things with it. One, longitudinally track kids over time, what's happening to this patient in terms of their radiation risk. Two, identify if there's like cohorts of kids like Tommy that we need to prospectively put some clinical services around to make sure they don't get overscanned. And then three, see if we can do some interventional studies around clinical decision support. Yes, the pop-up when you try to order something. Sorry, residents. So this is what we did. We created something called the Dose Wizard. We, in our lab, like many pediatric surgery labs, much to the chagrin of general surgery residency directors, rely on our surgical residents to be an engine of our research. And so we had a surgical resident who actually had a master's in medical physics at the same time. So it was a perfect setup for us to do this work. And so we created this software tool working with a radiation epidemiologist at the NIH who had done all of like the basically the math, okay? He knew how to calculate total effective dose across every organ system. And we used that calculation, we put the software tool, we embedded it in the software tool so that we could merge this data together, and it would give us the cumulative amount of radiation that a kid got over time. And this would populate into some research, and it would also populate into a clinical decision support tool at the point of care. So after developing the Dose Wizard, we then implemented it at our institution, and in under an hour, it calculated the dose from over 26,000 CT scans, merged it with pre-specified data elements from the EHR, versus if I had poor Dr. Dan Lodwick, our resident, now pediatric surgery fellow, do this, it would take him 7.5 years of full-time work with a degree in medical physics. So we felt like we could implement it and it was an efficient tool, but was it real? Did it work? Was it actual real data? So we did a manual validation of a big diverse sample of these CT scans, and we found that it was 100% accurate. We could process scans from all manufacturers. We could upload them from the PACS system if kids were scanned at another center. As a tertiary quaternary pediatric center, that's important because we get kids transferred in and they come with their scans. So we need to be able to see how much radiation they got from the scans that they received at an adult hospital. And the goal of that is that if we had a tool that was so facile, we could disseminate it more broadly across the U.S. So remember, there are three things we wanted to do: longitudinal measurement, identify cohorts, and then create interventions to try to fix the problem. So let me just tell you a little bit briefly why longitudinal measurement is important. There's a thing, it's called the Pediatric Health Information System. It's a large database that we use in pediatric healthcare. It's an administrative database, and it goes across 47 freestanding children's hospitals. So if you want to see, do some HSR, health services research, this is a great tool if you're in pediatrics. So we put all the kids who had at least one CT scan in a 5-year period, okay, across 30 of these hospitals. And there were about 450 or so thousand patients. Then we took all the kids who had at least one scan a year. That came down to 26,000 patients. Then we said, well, how many of these are done at our hospital, a Nationwide Children's Hospital? And there were 849 patients who had 5,500 scans. So that's just, that data is just here on this table and this histogram, okay? And when you look at the table, we wanted to ask the question because we're trying to point out to you why it's important to measure longitudinally in kids. These are the number of kids, 117, who had at least 10 CT scans over a 5-year period. And when you look at the histogram, you can see that it encompasses these patients, okay? But what we care about for longitudinal tracking is this patient. So who is this patient that had 54 CT scans in 5 years? That's a lot of CT scans for a kid to get, right? So we pulled that single chart and we did a deep dive into it. And we actually found that the database didn't capture everything. This child had over 70 scans in 5 years. If that were your kid, wouldn't you be asking the question? Has my kid had too many CT scans, right? When you go back 10 years in this kid's medical record, the child had over 120, that's over 250 millisieverts of radiation. Now, I am not a medical physicist. I'm a facilitator of this research, but that's a lot of radiation. That actually confers a malignancy risk between 7 and 8% above and beyond their standard risks. Okay, so that's just for medical imaging. And as it turns out, this was Tommy. So very strange that it came full circle, but this is him. So it was his mom that kind of triggered this research program, and we ended up looking at him as the patient to study longitudinally. So how can we use this? Well, we can use it to power something like a clinical decision support tool. Because remember I was telling you, right? PACS is one system, EPIC's another. They don't talk, and there's no way as a resident in the ED I'm looking at any of this stuff up. So you could get a clinical decision support tool that will tell you, hey, warning, 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 this child has had more than 120 CT scans over his life. His lifetime risk for malignant degeneration is roughly 7.5%. Maybe you should consider some alternative imaging. Now, you can also take something like this. This is a mock-up. And you can take it out of the prescriber's hands and you can put it in the radiologist's hands or the CT tech's hands. It can live wherever you want. There now have been other software tools that have been developed to do similar things, but they don't merge data with the EHR as well as ours does. And we have now actually given this body of research over to our radiology group because they need to own it because this is really their practice. A couple of things we talked about. Can we have cohorts of patients that we can now follow? And so these are a bunch of different kinds of patients we followed to see, can we use this dose wizard tool to help identify risk with them? I'm just going to point out two real quick. These are obvious hypotheses that we knew we could prove. We didn't do it to make any big scientific knowledge. We did it because we wanted to say, hey, the tool works, and it makes sense because our hypothesis is in line with what the tool's doing. So you may or may not know this, but in medical imaging, radiation is dosed based on weight. So really important in pediatrics, right? So if I gave a little tiny baby the same amount of radiation I give a 300-pound adult, that would be a lot of radiation for that baby to see. We can all imagine that's the case. And so the radiologist did something very smart. They came up with something called Image Gently, or ALARA, which is use the lowest dose possible you can to get the images you need. And so we have weight-based dosing for radiation for CT scans. The problem is they put that in place to protect the babies. But what happened to American teenagers in the last 15 years? Anybody? Anybody? They got fat. Okay, we're all getting fat. They got fat too. And so what happened is we started giving these teenagers tons of radiation with their CT scans. And so, whoops, let me go back. And so we did find when we pulled any kid with a BMI greater than the 95th percentile that they got more radiation, not just the dose, but also even they got more scans, right? We don't ultrasound obese patients very often. We go right to CT scanning. We do that in kids too. The second hypothesis was around trauma patients. So when you guys have a trauma patient come in who's got a bunch of injuries, I imagine you do a lot of scanning. Okay, I would do that too as an adult trauma surgeon or as an emergency medicine doc, but we don't do that in kids necessarily. And so we hypothesized that kids that were treated initially at adult centers and then referred to us would have more radiation exposure than if they came in directly to us. And we are not trying to change referral patterns in pediatric trauma. That makes zero sense whatsoever. That would put kids' lives at risk. That's not what this is about. It's to say that the tool works, and it's to say that, hey, there might be some opportunity here for education. So all this like dosing parameters we use in children, we need to teach like the adult radiologists maybe how to do that a little bit better, and maybe how to interpret CT scans that are a little fuzzy, because what does radiation do? It gives you beautiful pictures. When you look at baby CT scans, you're like, is that the liver? Like, what is that? You don't really know. So that's a whole skill set that they have to learn to interpret these fuzzy CT scans. So it's just an opportunity to do that. And so we really thought in this body of work that leveraging a bioinformatics approach, so creating a software tool and trying to implementing it in clinical practice, would help facilitate population studies on radiation burden in children for those three things that we talked about. And so similar to the appendicitis work, this is the kind of work that was led by a family's observation, an expression of what they care about, and then studying it in the way that they care about it to answer the questions that they care about. So this is the third case. This is Emily, and this is a 15-year-old girl who came to Nationwide Children's Hospital with abdominal pain. Imaging studies suggested that she had a complex adnexal mass. She was booked and consented for a probable oophorectomy, and her parents wanted to know if there's any way they could save the ovary. Now this is actually Enter Payam Sadai, who, yes, I trained Payam, but Payam trained me. I mean, anybody who knows him knows Payam gets what Payam wants. So Payam was the fellow on call when this patient came in, and I booked the case, and he was like, Dr. Deans, I don't know if we need to take the ovary out. I'm like, what are you talking about? We're taking this ovary out. Like, I'm not going to be messing around in the OR. It's Saturday or Sunday or something. And so he said, well, maybe we should consider calling the gynecologist. I'm like, I'm not calling a gynecologist. It's an ovarian mass, right? Because in pediatric healthcare, we are the pediatric gynecologist. It's a new field. This pediatric adolescent gynecology group is pretty new across the country, and they do a lot around STDs and adolescent health, but they're not in the operating room as much as we are. So we've always been the gynecologist for children. So it's Payam, and so I always listen to him. And I said, okay, I'll give Dr. Hewitt a call. So I called Jerry Hewitt, who's one of our pediatric and adolescent gynecologists. We're very fortunate to have them. Most pediatric centers do not. And I thought she was going to say, you cannot do that laparoscopically. You are crazy. And what she said was, yeah, I want to take the ovary out. And I was like, what? Okay. And she said, why don't I come in and do the case with you? And I thought, oh my gosh, there's going to be a gynecologist teaching me how to operate. This is going to be interesting. So she came in, and she was very kind, and we did the case together. And I kind of walked out of the OR like, oh my God, how many ovaries have I taken out that I didn't need to take out? That's a really scary thought. Because no offense, boys, but when it comes to testicles, we are all caring about them, okay? When it comes to ovaries, like, she's got another one, she'll have babies, not a problem. So basically, I decided I would ask all my partners, what would you do with this case? And all 15 of them said, yeah, I would have taken the ovary out. I thought, okay, well, I'm not the only idiot. And then I said, okay, well, let me send some emails around to people that I can trust around the country. And all but one pediatric surgeon said they would take the ovary out. I thought, okay, either the gynecologist was smoking crack that day and I should have taken that ovary out, or I am totally off base. So this started a research program around what do we need to do to protect hormonal health in adolescent girls, and is there a disparity in care around how we take care of them versus the gynecologists who are really, honestly, more trained to take care of hormonal health issues. So the objective of this research program was to first describe the variability in surgical management of these benign ovarian neoplasms across tertiary children's hospitals, with the goal of reducing unnecessary oophorectomies for benign disease. Let me just put this all up on the board because it's a lot of detail and you're probably glazing over at this point. We went back to the FIS, this administrative database for children, and we pulled all the kids who had a benign ovarian neoplasm. We confirmed that's what they had, and then we said, what kind of surgery did they have, okay? And a little over half had an oophorectomy, a little under half had ovary sparing surgery. So we dove into that information. The first thing we did is we said, well, are we all doing it the same way? Or are some hospitals doing better than others with this? So the x-axis is the hospital number. You're probably used to seeing these with NSQIP data. The y-axis is the percent of patients who had an ovary-sparing procedure. Okay, I'm going to try to use this mouse. Let's see how it works. So if you save ovaries, you're over here. If you take a lot of ovaries out for benign disease, you're over here. So the goal is to be over here, but also to move the line, right, to get everybody a little bit more on equal footing. And so when we dove into this information, we identified that if you were older, if you came through the emergency room, or if you were treated by a pediatric surgeon. Oh, no, sorry, if you're younger, came through the emergency room or treated by a pediatric surgeon, you were more likely to lose your ovary. So what I really cared about was this disparity in practice across the two fields that are seeing these kids. So we dove deeper into what's happening based on the doctor. Well, pediatric surgeons, for benign disease, we take out 64% of ovaries. And the gynecologists do the exact opposite. So why is this happening? Well, as surgeons, we see a mass. What do we want to do? We want to reduce the potential for malignancy, right? We want to take out any potential cancer, and we are very fear averse, risk averse as pediatric surgeons. We also want to reduce the potential for recurrence because that's a bad outcome, and we want to reduce the potential for reoperation because that's considered a complication with what we do. See, the gynecologists, they don't view it that way. Yes, they want to reduce the potential for malignancy, but they don't do that in the operating room. They do that where they are happy, which is outside of the operating room through preoperative risk stratification types of things decision making that they use. They are also, of course, they don't want to have recurrences and such, but they are more focused on preserving hormonal health. So if you have a benign neoplasm and you take it out and you save the ovary, and it comes back, what do? You go back in, you take it out again, you save the ovary. They don't view that as a complication. To them, yeah, it's not optimal, but it's not a real complication. In addition, they don't really view all tumors, these pediatric and adolescent gynecologists, as potentially malignant. So it's very different than the adult gyn-onc world. In fact, when we actually look at data, just as another little sidebar, we do it worse than pediatric and adolescent gynecologists, but the adult gynecologists do it worse than we do. So they're taking more ovaries out than we are, which is interesting. So we decided that we needed to modify our approach as a field, and of course there are people in our field who had been doing it right all along, but in general, we needed to address it more broadly. It is a population-level problem. There are 20,000 females diagnosed with these benign ovarian neoplasms every year in the US, and 90% of them undergo surgical resection. And this is what scares me, is that up to a quarter of them will develop a contralateral lesion. So if you take out one ovary, and they get it in the second ovary, and that's your practice, what have you just done? Anyone? Castrated. You've castrated the child, okay? Let's say you take out one, and the child becomes a teenager and gets big ovarian cysts, and they torse their ovary. What just happened? Castration, okay? So whether it's surgical castration or accidental incidental castration, it's castration. There are, in addition, long-term implications for oophorectomy in childhood if you just take out one ovary. And I don't think we ever thought about it that way. I mean, I certainly didn't. And listen, I went to all-girls high school, women's college. I'm like feminist to the 20th degree. I mean, I am, right? I mean, truly, I am all about girl power. And I don't think I ever really thought about what are the implications of taking out one ovary. Well, there are a lot. So there's this thing called premature ovarian failure, and this is all coming from the women's health literature, but if you've had one ovary removed, you're more likely to go through menopause earlier, which is part of kind of a premature ovarian failure picture. But you have higher rates of heart disease, higher rates of neurologic disease, lower bone density scores, so you're going to break your hip and die sooner. You have impaired sexual health, shorter reproductive lifespans, that's kind of a no-brainer, and you have a poor response to in vitro fertilization. So you can't get pregnant, you want to get pregnant, and you have a poor response to anything the medical system can offer you. That's kind of the reproductive message there. I've oversimplified all of that, so I'm hoping none of you are gynecologists. So in response to this, we created this massive algorithm. Please don't even look at it. It's just too busy. But I put it up there because this was the result of a stakeholder team. Okay, this is the result of bringing people together who care about the problem, care about the intervention, have to use whatever intervention we decide is best. So we brought them together to develop this algorithm. And there's several key concepts with it. One is preoperative risk stratification has to happen. The decision to take the ovary out happens before you go to the operating room. It does not happen in the operating room. A multidisciplinary discussion. So invoke your radiologist, invoke your medical oncologist, talk to gynecologists, which is really what Payam taught me. Lack of emergency around a non-torsed ovary with a lesion on it. You don't have to do it in the middle of the night. Okay, if it's not torsed, you can sit on it. You can get your tumor markers. You can get some additional imaging. You can do you can have that multidisciplinary discussion. It's not an emergency. And then reoperating on recurrence of benign disease is not a failure of treatment because you saved the ovary. Okay, it's like a whole shift. So we took this algorithm, we put it in our institution, And our oophorectomy rate dropped from 73% to 4%. We had not a single missed malignancy among patients for whom the algorithm was used, which means that it wasn't used all the time. And we had one surgeon, who will go unnamed, but it's funny that it was this person, who didn't use the algorithm. And they missed a sertoli Leydig tumor. So they did an ovary-sparing surgery in the wrong kid. And that kid had symptoms of hormonal changes and imaging features that when we put it through an independent board said, yeah, I would have not done an ovary-sparing surgery in that kid. And so we've adopted it into clinical practice. And so what's happened is, here's that figure I showed you before. We went from being the worst outlier in these hospitals to being one of the best. So when you talk to our stakeholder team about that, it's like, oh my gosh, yeah, let's do something with that information. So we went and got some funding, which is really important, from the Thrasher Research Fund, because you need money to do work. And then we rolled this out to the Midwest Pediatric Research Consortium, which is a consortium of children's hospitals, and we all do clinical research together. And so that's ongoing right now. It's a prospective study looking at the use of this algorithm. We also have this thing called PedsNet. Is anybody here familiar with the learning healthcare system? No, okay. Yeah, a couple people. So PedsNet is a learning healthcare system. What that means is it's funded through PCORI, through something called PCORNet, where healthcare systems come together and they decide they're going to have a common electronic health data process, okay, a CDM. And that means that all of our EHRs should be talking, and we can pull patients across EHRs, and we can do research that way, both retrospective and prospective. You can actually do simulated randomized controlled trials for things like this. So we pulled all this data from PedsNet. We said, let's take this algorithm and let's throw it across these 8 children's hospitals in PedsNet, and let's see what the results are. We could sort of simulate this quality improvement work, so to speak, okay? And so that's happening right now. And the truth be told, you probably don't need to do this prospectively. You probably can do something like this in a learning healthcare system environment. And that's something that families would also want, right? Because when you do clinical research, you have an idea. All right, it takes a year to like figure out how to write it up and get it going. Then there's like a year to start the work, and there's another year to get the work done. There's a year to publish. That pipeline from like idea to let's change clinical practice is really long. And if we're talking about something so compelling like this, we want to shorten it down. And so you can use these learning healthcare systems to do stuff like that. So this is the last one. I'm hoping I have a little bit more time. This is Jared. Jared is a 15-year-old boy with pilonidal disease, and he's had 6 incision and drainage procedures. I have to look at my notes because he had so much done. Had over a dozen courses of antibiotics, had an excisional procedure with a VAC dressing, which is, awful in children, and so had healed through secondary intention. And his mom presented to the surgical clinic with a re-emerging pilonidal sinus. He's missed over 3 months of school, a lot of sports. His grades suffered. He feels stigmatized, and he describes periods of feeling isolated from his peer group. I mean, he's a teenage boy with a big butt wound. Like, it's awful, right? He's the stinky kid at school. I mean, you had to have a vac going to all his classes with a smelly vac coming out of his pants. Like, this is an awful way to live when you're a teenager. So his mom said, is there anything else we can do to prevent it from coming back? And I'm thinking to myself, ooh, I could send you to an adult colorectal surgeon. That's what I should do. But no. So Pete and I decided, we all hate pilonidal disease. Anybody who loves pilonidal disease? Anybody love it? Anybody? Yes, all right. Exactly. You want to take care of it. You want to own it. Nobody wants to own pilonidal disease, right? They get tossed from doctor to doctor and clinic to clinic and ED to ED. Nobody wants to own it. So Pete and I had a little heartfelt conversation, and we said, do we really want to be the pilonidal pediatric surgeons? No, but we need to help this problem because the patients are really suffering. So I created a pilonidal clinic. We also then decided we were going to study pilonidal disease more broadly. So just by way of background in kids, you know what the incidence is across all age groups, but 1% of all adolescents and young adults will be diagnosed annually. So when you think about how many teenagers we have in the U.S., that's a lot of kids. That's 420,000 teenagers with pilonidal disease at any one time. So it is a public health concern. Recurrence is reported to be around 40%, sometimes higher, sometimes lower. The studies are not great. And there's a lot of wound complications post-resection, which I think everybody's aware of. So the first thing we needed to do is think about what was going to be our overall objective. So we take it back to our patient, and we were starting to put together a stakeholder group for the study. And really what people wanted, the patients' families, was to figure out if we could have some non-invasive ways to prevent recurrence in this disease. So we decided we'd take a multifaceted approach like we've done with other things. The first was, because there's so little data in kids, we needed to characterize the burden of disease and sort of find the evidence gap that we could maybe answer. And then we needed to identify potential adjunct therapies that were not invasive and then study them to see if they work. So we went to the literature, and I'll speed through this stuff. We found that recurrence rates after INDs were roughly 30 to 40%. That's not surprising to anyone. Recurrence after surgical excision was like 10 to 30%, also not surprising. But most of these studies were done in adults, and they were really focused on comparing surgical techniques. Like, we're surgeons, we like to know, like, does this stitch matter? Can I do this flap? Right? This is like what we traditionally have done. But there was little data to inform pediatric outcomes, and certainly very little on non-invasive techniques. So we did a multi-institutional study, again using that FIS database, and we basically found that recurrence rates were high in teenagers, okay? And even recurrence rates from excisional stuff seemed to be higher than what was in the adult population research. We also then went and dove deep into our own institutional data and wanted to see, okay, are we maybe underestimating the recurrence? And in fact, we probably were. The bottom line of all of this is we identified that recurrence at our own institution was about 33%. And once someone recurs, they're going to recur again, and that just exponentially goes up. So a recurrer is a recurrer. So we put together a stakeholder group, and this is comprised of all the same people I've showed you from other stakeholder groups. But we also engaged leaders from some of the professional societies and online groups because we felt like we were going to need them to help with the dissemination process in terms of what our results were going to be. We had in-person group meetings and interviews, phone calls, and surveys, and the bottom line of all of it was that everybody agreed across the board we need to try to prevent recurrence and do it non-invasively. And these are the reasons why. It's not surprising. I'll just point out one thing specific that's different than adults is that these are teenagers, right? So, like, does anybody have teenagers? I have 2 teenagers. Oh my God, what do they care about? Other teenagers, themselves. Like, it's all about the socialization and how they look and all that stuff, how they feel. And so it's very emotional heavy. And when you take a kid who has, you know, a big butt wound, it messes with their psyche. I mean, it really does. And you might not know this, or maybe you do, but there's actually a disability code. So you can graduate from high school and go on full-time disability for pilonidal disease. Okay? And we've had lots of kids who've missed a year of college because of it, years of school, all that stuff. So it was pretty compelling as a pediatric healthcare provider that we needed to do something about it. We did a systematic review to see what kind of other treatments besides surgery are out there to help with this, and one of the things that came to the top was hair removal. So the American Society of Colon and Rectal Surgeons actually says you gotta take away the hair and have really good hygiene. Not surprising. So we thought about laser hair removal because, again, think of the teenager. I don't want mom shaving my hairy butt, okay? Like, that's what it looks like. These are teenagers have to have their parents, caregivers, do all this, or their college roommates. Could you imagine that? So we went and said, what's out there around laser hair removal? And we did a review of the literature, and we found that there were about 35 studies that looked at laser hair removal. Only 5 of them had comparison groups, and only 2 of them were RCTs, and essentially none of them had children. So we really didn't have any pediatric-specific, high-quality research to inform whether laser hair removal would be a good therapy. So what do you think we did? We created a trial. I'm going to skip through that, looking at laser hair removal in pilonidal disease. We started out with a pilot, just like the API study. We put 13 kids through this. It was very, very small because it's expensive to do laser. And we just found it's tolerable. Like, if we numb up their butts with cream with EMLA for 45 minutes, we shave them, and we laser them, their pain scores are like 0. And we had no recurrence of pilonidal disease at, I think it was 13 months. Yeah, 13 months post follow-up. So we used this preliminary data and all the other stuff I just showed you about the literature and what families cared about. We went to PCORI and said, we're back, we have some more studies, and they funded us. And so we have a randomized controlled trial that's looking at laser therapy plus like regular mechanical or chemical depilation versus just standard care depilation. And the aims, of course, were to see if we could drop recurrence rates, but then really focus in on those patient-centered outcomes that the families cared about. We're in our 18th month of enrollment right now. We have 166 patients, and we've had no serious adverse events. So I can't share any data because we haven't had our interim analysis yet. But the bottom line is that pilonidal disease is a common problem in teenagers. It's a significant public health burden, and the families care about it. The morbidity is related to recurrence rates, and there are some potential non-invasive things like laser hair removal that we need to study to see if we can help these kids. So just in conclusion, although each of these children presented with a very different story all of their stories impacted our research agenda and led to significant alterations in how we care for kids, at least at our own institution. And so I'm going to get on a soapbox, and I promise I'll only be there for about 10 seconds. But when we reflect back on like the key factors that made these programs, these projects successful, it really was listening to families, studying what they want us to study. So I'm just going to charge you with this. If our goal, just as a doctor, not as a researcher, if your goal is to improve the quality of life that your patients have, okay, don't we need to listen to them to find out what they think is driving their quality of life and then study those things? So thank you for your time, and I'm happy to take any questions you might have.
So Kate, first I just want to say thank you very much. That was spectacular. It really, it seems so obvious.
Right, so
Shouldn't we just listen to our patients? But, how many times do we not do that? We have a little token of appreciation for you to take home, and as I now tell everyone, you can get through the airport with this. It's not considered a weapon, and it's our cute little, as you came in, our sort of little DNA over the top. But anyway, thank you very much.
Thank you
Really
so
great.
much. Thank you for having me. Appreciate it.
So we do have time for questions, so take it away. I think this was really an inspiring talk. Dr. Hiroshi.
Dr. Dean, thank you so much for an inspiring talk like that. It's really phenomenal, and I
you.
really appreciate you coming and talking about things that are really near and dear to our heart. And I know that sometimes appendicitis and pilonidal disease doesn't seem very sexy, but it really is. It makes such a big difference, and I just want to say thank you. I had a couple of just sort of questions for you.
Sure.
You had payers in every single one of your
Absolutely.
stakeholders, and I know that you're saying you had a big ACA in your state.
Mm-hmm.
So did you have a person that was your sort of go-to person, or how did you get those people interested and engaged? And my other question was, in terms of your clinical decision-making stuff, was it just a pop-up window, or are you trying to make it so that there's alternatives that are suggested in sort of more of a decision tree that's presented versus just hey, you should think about this?
Yes, great question. So the first one, the Partners for Kids is the name of our accountable care organization, and so we had the CMO as part of our stakeholder group, and I just approached him. His office was down the hall from mine. I'm also, or was, the vice chair for Partners for Kids, so I had a little kind of in there. He has subsequently become the president for that organization, and he's a practicing pediatrician who's kind of gone into the way of administration. So I think it's important to get the payer on board, because these types of interventions are going to change that landscape potentially, right? So we had a couple instances where private insurers would not pay for the non-operative management admission. And so we had to kind of go to bat for that. And then we have to provide evidence through a mechanism that's going to get dispersed to the payers in our area that, hey, this is a treatment paradigm. It is saving money, which is why that cost savings was important. And so you're going to get bills for it, and we need you to approve it. And then our hospital kind of ran with it and did that. The same thing for pilonidal disease. So we can all prescribe laser therapy. They can go to Medi-Spas and do it, right? The problem is they might not use the right laser. The Medi-Spa doesn't care about the outcome, really, because if the hair comes back, what are you going to do? Come back and pay more money, right? And insurance really doesn't pay for it. It's really hard to get insurance to pay for laser therapy. So we really want the information. That's why we did the trial. That's one of the reasons we did a trial. To show the payers that you should pay for this. It's actually going to decrease the cost of pilonidal disease across your population. And PFK is a good venue for us to do that because it's managed care for us. We're accountable for it. Your second question real quick was the clinical decision support tool. So that's a mock-up of the tool. That's not the tool that's actually used. We turfed that body of research to the radiologists because it got to the point where the American College of Radiology was trying to develop their own. American College of Radiology is an interesting professional society. It's much more geared to like the private practice doctor, and it's almost like runs like a business a little bit more than some of our professional societies do. And so we turfed it to them to actually take the technology and use it. And so what they're doing is a little bit more regimented, right? So you meet these criteria for head injury, all that PCARN data. So this kid should not get a CT scan. They actually block you from ordering it now. Like there's other things that come up. And I think it needs to live with the radiologist, not with the prescriber. There's too much fatigue in these pop-up buttons now. When we were developing that, clinical decision support windows were pretty new still. And now there's just too many of them. So there needs to be a better way.
Dr. Ali.
Really, really enjoyed your talk, so thank you very much. As a bariatric surgeon, a lot of these things resonate with us, especially for, when patients are very involved in the decision making and asking questions. I love the fact that as you went through the cases that you presented were where the outcomes of your research was in alignment with what the patients thought they wanted. Now, I'm curious, have you had situations where the recommendation from your research data was against what
Yes.
the patients, and so my questions are really about, I imagine socializing that message is a little bit different than socializing it when it agrees, and I was wondering how you approach that.
Yeah, that's a great question. And the study with the iPad app around shared decision making for early appendicitis, that was a negative clinical trial. Right? It was a funded clinical trial, and it was a negative result essentially. So we showed our primary outcome around have we improved decisional efficacy and confidence with decision making by using this iPad app was no, we haven't. There's no difference. And so patients didn't really like that, right? Because they developed, our stakeholder team developed that app. But it was, I think, informative for everyone. Hospitals are starting to put a lot of money, or at the time, we're starting to put a lot of money into the shared decision-making apps. And when you start to show there's no difference, then whether patients want it or not, we kind of have to communicate that. I will tell you, when you have a trial that has a negative result like that, it's important to understand if the negative result is erroneous. And if you did something in your design, and we did. Okay, and this goes back to the stakeholders too, because one of the things that they requested for our recruitment purposes was that, excuse me, we needed to have a physician be the one to approach the patient, so not a research staff member. So our surgical residents, on call 24 hours with that iPad app going down to the ED, very motivated for Dr. Deans and Dr. Minetti to have a good study because they want to match in pediatric surgery, right? Doing a really good job. The way they counseled patients without the app was pretty much the app, right? So we washed out our p-value because our surgical residents were so good, right? That's probably not how, I mean, maybe it is because I'm so invested in non-op management, but that's not how like the average ED doc or surgeon coming in the middle of the night to a patient is going to talk about the risks and benefits. So we maybe hurt ourselves by listening to the patient perspective of we want to have a physician doing this. We maybe should have said, you know what, that will hurt the science. We can't have a physician doing it. We need to have a research staff member who doesn't have all that information. So yeah, it goes both ways.
I just want to echo what Dr. Ali said. Thank you for your beautiful work. I just think it goes to show when we start with a true story, the research results in not only telling a more accurate story, but can result in like a happier ending. And it's just a very lovely thing. I studied a lot of community-based participatory research in undergrad and kind of public health school. It's typically used more in like the behavioral health realm, but it just goes to show when you start with your subjects and what's important to them, sometimes you discover that what you think is important isn't what is most important to them. And so, thank you.
It's a good parenting tip, too.
Yeah.
and faculty tip. Well, thank you very much.
Oh,
We've got
thank
a
you.
long day for you.
Excellent.